Dr. Mohammed, we can't hear you. Please unmute yourself.
Yes, hello. Can you hear me?
Yes, now good.
Okay, thank you very much for the opportunity. I'll try to explain briefly about our experience in Indonesia. We've been doing this for 3 years. This is a historic moment in Indonesia. We try to transform cerebrovascular care, and neurosurgeon play a very important roles. This is a brief data of stroke in Indonesia. And we are a big country with 275 million people across more than 900 inhabitant islands and 10,000 islands in total. So it's a logistical nightmare. The distribution of tools and human resources are very difficult. We have 5 major islands with 36 provinces, and the current Ministry of Health is very ambitious about doing a significant transformation. This is where we are at 2021. As you can see, our number are very bad. We only have 9 comprehensive cerebrovascular center, which is a center capable of doing from thrombolysis until definitive treatment of microsurgical endovascular treatment. We only have 12 thrombectomy-ready hospital, and primary stroke center capable of doing thrombolysis are only 7 at that time. This is very dramatic, and we want to increase this number in the shortest period of time. So we have 6 key strategies. We first we create our own hospital tier system. So comprehensive stroke center will be named an Utama hospital, which is capable of doing thrombolysis, thrombectomy, and surgical clipping. And then thrombectomy capable hospital, we call it Madhya Hospital, which is capable of doing thrombolysis and thrombectomy. And our primary hospital will be Dasar Hospital, capable of doing only thrombolysis. And we created the Paripurna Hospital, which is the highest tier of hospital system, capable of doing everything, and also have a responsibility to train another hospital to be able to do cerebrovascular services. And we also determine what kind of tools and what kind of services should be done in each tier hospital. This is, for instances, Paripurna Hospital have the most tools from imaging, microsurgical tool, and endovascular tool. Madhya Hospital at least can do high-speed, can do ICH evacuation, decompression. So at least they need to have a high-speed drill, neurosurgeon, or trained general surgeon. This is the system that we've been testing and implementing for the last 3 years in our country. We also create a proctoring SIM using that tier system. So the Paripurna Hospital will train Utama Hospital, and then Utama Hospital will train more Madhya Hospital, and Madhya Hospital will train Dasar Hospital. So with this tier system, we hope that we can effectively increase the number of stroke-ready hospitals in our country in the shortest period of time. We also do the mapping of each provinces. We have the 514 districts across 36 provinces. So we identify which district to prioritize for the next 5 years. This is example of Aceh district, is our northern part of the Sumatran island. This is Borneo, and this is Bali. You probably all know about Bali. We try to map the district using QGIS to determine which hospital to prioritize based on the golden period of 4.5 hours for thrombolysis. So the target is to create 34 Utama hospital, which means all provinces are capable of doing clipping and endovascular treatment. And then our target is all district, which is 512 in this number, is capable of doing thrombolysis, thrombectomy, and coiling. And there will be no Dasar hospital in the future, which means all district hospital will at least capable of doing basic endovascular services. Currently, we have 9 Paripurna hospital, but we hope to increase also the number in the future. This is 9 hospital across Indonesia, and this hospital, 9 neurosurgeons in this hospital are responsible in training younger neurosurgeon in another provinces and district to be able to do cerebrovascular services. We also train, of course, the nurse and their interventionist, intraoperative nurse, and the other supporting system staff. This is where we are at the middle of our program, which is in 2024. We have 16 provinces capable of doing clipping, and we plan to increase that to 34. We create a short training program as well. This is 6-month intensive training program. We train 20 neurosurgeons from 20 provinces. It's a hybrid program of hands-on course, live surgery, and also webinars. We include all the big neurosurgeons across the world, like Professor Okuya Tanikawa, Professor Michael Lawton, and Professor Subin. And this program, for 6 months, we use innovative cerebrovascular models for hands-on training because cadaver are very, very expensive. We fly to Barrow to gain some consult about innovative neurosurgical training, and they created for us a full 3D printed head models, which is way cheaper than human cadaver. We do a training for 20 neurosurgeons. And by doing that, we increased the number of clipping-ready hospital by 34 by the end of last year. This is the proctoring sim, which the neurosurgeons from Paripurna Hospital fly to a smaller district or province doing cerebrovascular surgery and open vascular surgery. And as you can see here, this is our Ministry of Health in white shirt. He is very supportive. He even come to the OR to see the surgery live. He come to see the patient. This is on the national news, so public relation is very important in this program to raise awareness of the public about the importance of this transformation program. So current updates, we have trained more than 1,000 healthcare workers for code stroke. We do a dozen of case proctorings in a lot of hospital. We train more than 251 nurses in 88 hospital. This is the increase of numbers of thrombolysis, thrombectomy, and clipping-ready hospital. And we also, with the government, do a short fellowship program for neurosurgeons, 6-month hybrid training of open and vascular surgery. This is the number of go-through activities. This is our clipping-ready province now, which is 31 provinces, 3 more provinces to be trained, and there are 4 new provinces in the Papua Island that will be trained in the next 3 to 4 years. This is our thrombectomy and coiling ready hospital now. It's still a long way to go. We only have 94 districts now, which is dramatically increased from the beginning of this program in 2021, but we still have 300 plus districts to be trained to be able to do thrombectomy. And a future directive is we are increasing our fellowship locus. We already signed agreement with a lot of overseas fellowship centers. We send a lot of fellows now to another country to fulfill the quota. And this is the number of neurosurgeons in Indonesia. We only have 560 neurosurgeons, and it's only across 136 districts. So we are short 378 districts without neurosurgeon. This is the map showing where the general surgeons are. So we decide to train general surgeon to be able to do our job. I also want to show the gap. This is the gap of insurance coverage. That's why microsurgery are still very important in our country. We are doing high flow bypass, bypass for moya moya, and bypass for cerebral aneurysm. So this is a historic moment. This is my last slide. A historic moment for our country. We tailor protocol based on our geography, socioeconomy, and cultural differences, which we believe cannot be replicated anywhere else in the world. It's us against the disease, not us against each other. This is a picture of the head of Neurosurgical College, Neurology College, and Radiology College sitting together thinking about the future of our country. So we are fighting against the disease, not against each other. Thank you very much.
Thank you, Dr. Mohammed. And we'll move with our colleague to present our last speaker of the session.
Right, so I invite Dr. Ivana Roskova for her interview with Dr. Kenan Arnautovic.
Thank you so much for the very good afternoon, everyone. First of all, I would like to congratulate organizing committee for organizing this amazing event. It's a